So today I'll be talking about Kari-Mello syndrome. So what's that? So this syndrome recognizes that heart, kidney, metabolic dysfunction, and fatty liver are manifestations of one interconnected systemic disorder. This naming moves us away from organ silos. As of now, how do we treat our patients? The cardiologist deals with the heart, the nephrologist deals with the kidney, endocrinologist sugar, gastroenterologist liver. Is that the way to deal with a single patient who has all these problems? Definitely not. Carimello says it's the same disease, just different organs showing symptoms. So it explains why the risks multiply and not simply add. A patient with diabetes, CKD, and hypertension doesn't only have three problems. He is at an exponentially higher risk of heart failure, MI, stroke, ESKD, and death because the organs amplify each other's injury. Because they are in the same body, they interact and talk to each other. So Carimello means we no longer treat organs now. We treat a patient. We treat a shared disease network before it breaks us down, before it breaks down the heart or the kidney. So simple slide for pathogenesis. It all starts with a dysfunctional adipose tissue, and what it results in is inflammation, oxidative stress, insulin resistance, vascular dysfunction. So for any postgraduate, we know the pathogenesis for heart disease, kidney disease, liver disease finally boils down to the same, the things in orange. And this leads to cardiovascular disease, atherosclerosis, myocardial remodeling, fibrosis, cardiac dysfunction, renal disease, glomerular affected, tubules are affected, leads to CKD as well. And again, we have all heard about MASLD so many number of times. So all organs get affected by a single pathogenic mechanism. There are multiple stages of Carmelo, but what is the one practically sitting in the clinic you should always remember? First stage, stage 0, we may say 0. Those of you young here, you may be having stage 0, normal, no risk at all. You are absolutely fine. Stage 1, maybe people like me, excess body fat, insulin resistance, so a little bit BMI on the higher side, waist circumference on the higher side, but the organs are still normal. Then some of us, stage 2, diabetes is there, dyslipidemia is there, stage 2. The others are perfectly okay as of now. Stage 3, it's dominated by kidney. CKD gets established. Heart failure or heart disease may be early. And stage 4 is overt cardiovascular disease. So remember, each stage has one specific identifier. That should be very clear. There are multiple classifications, but this you'll remember anytime sitting in the clinic, because this is not theory, this is practical. The patient comes to you in your clinic. You have to find out what stage of Carmelo he is in, or whether he has the syndrome at all. So this is a day-to-day practice where type 2 diabetes visits you for the first time, 47 years male. He is having diabetes for 5 years, hypertension 3 years, and doesn't have any cardiovascular disease overt. So as of now, he has diabetic retinopathy though, smoker, ethanolic, mixed diet. He is obese. BMI is 28. He is hypertensive as well. Visceral obesity. Waist circumference is 110 centimeters. And all parameters. HbA1c is abnormal. Creatinine 1.9. EGFR is 43. He has albuminuria as well, 600 milligram, which is missing there. Serum albumin is 3.5. And cholesterol is 250. LFT as of now is okay. Ultrasound shows a fatty liver. Fine. And he has other reports as well. Grade 1 diastolic dysfunction. Pretty common scenario of most of the diabetic patients who come to us. And generally what the prescription looks like, metformin for sugar, telmisartan and glimepiride. And this definitely needs to change. Is this a evidence-based prescription? Definitely not. Does this individual have this syndrome, Carmelo, what we are talking about? Yes. Type 2 diabetes, obesity, visceral obesity, CKD stage 3BA3, heart failure with preserved ejection fraction, fatty liver. So definitely syndrome. He's not only a type 2 diabetes, has hidden so many other problems. And remember, Indian obese is different from a Western obese, unfortunately, because we are lean, thin, but still obese. Because our BMI cutoff for obesity is what? It is 25. Overweight is beyond 23. And Western cutoffs are higher. Even waist circumference, they are luckier. We are unlucky. For females, it's 80 centimeters and males, it's 90 centimeters. So all of us practically are overweight, if not obese, many of us. So how do we manage this patient? Those 3 drugs on the prescription, are they okay? Definitely not. The treatment care should start in nephrologist's office? No. In cardiologist office? No. Should start in family physician's clinic or anybody's clinic for that matter. Not in the dialysis unit, not in a cardiac ICU. The first step on the prescription, write the diet. We all know weight control. Tell him his height was 165 centimeters. So tell your ideal weight should be 65 kg. There are so many formula, but remember, height in centimeters minus 100, that should be your weight. Many people 85, 100, they don't even know what their ideal weight is, and we feel too tired to calculate. So just tell them a ballpark figure, the height minus 100. And we know refined carbs are out. Vegetables, anything can be taken for all, liver, kidney, everything. Protein 1 gram per kg. If kidney, 0.8 gram per kg. Vegetable protein is better. Don't stop vegetarians for taking protein even if they have kidney problems. Fruits can be taken. Most of the fruits, even for kidney failure, only those with high potassium like banana should be avoided. Avoid sweetened beverages. Coconut water should be avoided in CKD. So practically the diet is same. Healthy diet is the same for all, whatever name you can call it by. It's not moving. Oh, okay, fine. So the second point on your prescription should be lifestyle. Quit tobacco, physical activity 150 minutes a week, and alcohol is given there. So we should know how much alcohol, what limit is acceptable. So no need to stop completely, but this is the guideline you need to follow. Blood pressure, we all know. Previous speaker has beautifully talked about it. And Carmelino, generally it's 130/80, but if CKD, diabetic CKD, 120 is the guideline if the patient is not symptomatic and should be controlled with diet and drugs. Take care of the salt. Salt 1 teaspoon per day, sodium half teaspoon per day, and tell the patient you've stopped salt, but they come with all prescriptions, Lona salt, Himalayan salt, pink salt, whatever salt. All salt, is sodium, and you have to cut it down. Avoid processed food. Rock salt is also salt. Less salad dressing. You take them to tell them to take salt, they take it with lot of dressing. The whole point is defeated. Avoid soya sauce, papad, pickles. Use lemon instead of salt. Read food labels. Sweet biscuits are not sweet. They contain salt as well. So all those things are important. Salt is the cheapest organotoxin available in the market. I would say that. Now, drug treatment for hypertension, RAS blockers, yes. Coming from a nephrologist, yes, I would still go with the RAS blockers, though I do understand the importance of other drugs as well, and not baby doses. Telmisartan should be 80. That fellow was getting 40. And if Inapril should be 40 again. Mostly combinations are required to maintain a target of 120. So calcium channel blockers, diuretics plus RAS. Triple therapy is generally required. And if not controlled, we go for MRAs, spironolactone if heart failure or resistant hypertension. Otherwise, in diabetic kidney disease, finerenone is also used. Now, beta blockers, yes, as of now, classical indication cardiac, but European guidelines have put them as monotherapy as well. And definitely, I do agree with the previous speaker. So I think guidelines slowly will incorporate even the CKD guidelines, beta blockers as well. As of now, we use them for cardiac indications. So this was done for our patient. Diet, exercise, stopped smoking, and triple drug therapy. What next? HbA1c was very high for him. So this we need to target young patient, fit patient 6.5. Older patients, you can go for 8 as well. Stricter control if young, long lifespan, and less hypoglycemia risk. CGMs can be used. I mean, if HbA1c is a bit unpredictable. So that's important. And drugs. So whatever Carmelino syndrome you are having, the first drug starts with metformin. GFR more than 30, metformin even in CKD is the first choice. What should be the next drug? We have a host of choices, SGLT2, GLP1, DPP4, insulin, sulfonylureas, and pioglitazone. So this fellow has so many comorbidities, Carmelino syndrome. So what do we do for this Carmelo syndrome? Is we start with metformin. This fellow had a GFR of 43. So GFR 43 means we reduce the dose to half gram BD. This was done. Now what should be the next drug in that syndrome? Could it be insulin? Could it be sulfonylureas? No. Organ protection is the key word, holistic approach, and for that SGLT2 top the list. So that should be the next drug on the prescription. They are wonderful drugs, decrease weight, reduce blood pressure, cardioprotective, decrease hyperfiltration in the kidney, smart diuretics, do not cause any potassium disturbances. In fact, they reduce the potassium and can be added to the other drugs, reduce albuminuria. So wonderful drugs. And there are many studies for SGLT2 in Carmelo. You can see CAREMELO, you can see for cardiac, for heart failure, for post-MICV risk, For CKD, renal with diabetes, without diabetes, both. Then metabolic, type 2 diabetes for ASCVD, for CV risk, and liver for MASH. They are very good, but not as a standalone indication. So if you have MASH with diabetes, with other features, then definitely, but otherwise not a standalone indication. And these are the trials for postgraduates to remember. So you have trials for CKD, heart failure, and as well as for obesity. So you have evidence-based trials, and it is a strong indication. Patient may sue you for not using them in the first place. So SGLT2 should be a part of prescription. They delay dialysis if started early by 26 years. They reduce heart failure hospitalizations by 30%. So you remember, start them if the GFR is more than 20 and continue them till the patient goes on dialysis. Little bit dip in GFR is not a contraindication. Explain that to the patient. Only type 1 diabetes sick patient is a contraindication. Otherwise, these should be on your prescription. We did that. Patient was started on dapagliflozin, still HbA1c 7.8 and proteinuria is still there. What next? So this is the place where we can add GLP-1 RA in this syndrome. So again, as you can see, they have cardiac, renal, metabolic, liver, and obesity indications with evidence. So they are very good drugs. But important thing is, will you start this GLP in a non-diabetic patient? Will you do that with kidney disease? No. Generally with diabetes or obesity. So generally standalone indications are not there. But now Essence trial has shown that in liver disease for MASH, they can be given standalone without a patient being obese or diabetic. So that's important. And renal evidence is from FLOAT trial that these are organ protective, renoprotective as well, and cardioprotective. And again, you have major effects with all the other GLP-1 RAs. So it's not semaglutide annulled, but the evidence base is maximum with semaglutide. And again, these are Carimelo, all the trials for GLP-1 RA. And you can see, you can remember the names, the postgraduates can remember the names. But carry home message for a clinician is you have a strong evidence base and you should have a strong reason not to use the drugs. So this patient was started on semaglutide 1 milligram subcutaneously weekly. What happened? Albuminuria came down, but it's still 430. HbA1c is fine. Creatinine is around 2. What next? So what do we do next? You are sitting in the clinic, you have done RAS, you have done SGLT2, GLP-1 also is there on the prescription, Finrenone. And we are all aware of the molecule, non-steroidal MRA. It's indicated, remember here again, the caveat is for diabetic patients only as of now. So diabetic with heart failure, diabetic with kidney disease, this should be a part of prescription. Not in non-diabetic. Trials are going on and available as 10 mg and 20 mg tablets. Trials supporting are Fidelio and Figaro. And you can see significant cardiovascular risk reduction, 14%, and CKD risk reduction, 23%. So again, very useful for Carimelo syndrome. Remember, make sure potassium is less than 5 when you are starting it. If the GFR is between 25 to 60, 10 mg. If it's more than 60, 20 mg. Intensify after 1 month. If you started with 10 mg, you can go to 20 mg after 1 month. The treatment can be continued till the GFR drops down below 15. For SGLT2, it was around 20. Here you can go till up to 15 GFR. Only thing is if potassium is high, 5.5 or more, then you have to stop it. Get down the potassium by stopping other juices, look at NSAIDs which may cause hyperkalemia, add potassium binders, try to continue the drug for organ protection. If you were to be the patient, won't you want a life free of dialysis, free of ICUs? Definitely we would. So it's important to stick to guideline directed medical therapy. Try to continue this as far as possible. So this patient now is on diet, exercise, telmisartan, amlodipine, chlorthalidone, metformin, DAPA, semaglutide, and Finrenone. Is that all? Let us see. So we have added one by one sequentially RASI, SGLT2, and GLP and MRA. Can we add them together? So that's a commonly asked question. So confidence trial gives us confidence that you can start SGLT2 and Finrenone together. That can be done. And in fact, the hyperkalemia risk gets mitigated because Finrenone causes hyperkalemia, SGLT2 reduces the potassium. So it's a good combination and whopping 52% reduction in renal endpoints, proteinuria, significant reduction. So we were also a part of the confidence trial, FLOAT trial, and hence confidently I can say that does improve the outcomes in Carimelo syndrome. So I would comment saying RASI started the journey, SGLT2 changed the game, GLP-1 RA added benefit, and Finrenone has closed the gap. Is that all? What else? So if the patient is obese, as was our individual, so if the BMI is more than 30 or if the BMI is more than 27 plus comorbidities, our patient came into the second category, then these drugs, semaglutide, tirzepatide, the liraglutide, the GLP-1s are good for reduction of the weight. The older drugs, orlistat, topiramate, and bupropion are no longer used because of the side effects. So out of these drugs, the commonly used ones are sema and tirzepatide. So both are available. And are they good for the syndrome? Yes, they are good. Semaglutide 10 to 15% weight loss. Tirzepatide is dual GLP and GIP analog. So this is also used for obesity, weight reduction, and this also causes a significant weight loss. So flow trial for semaglutide for renal outcomes, tirzepatide renal outcomes with surpass trial. So as of now, semaglutide has come as a part of guideline for the renal part, Caramello. Tirzepatide has yet to come, but trials are going on. Both are good molecules available in market. The main thing is the cost. The other important thing is the patient's tolerance. The GI side effects are prominent, but again, they are very good drugs. Important to rule out active diabetic retinopathy, rule out a history of carcinoma, medullary carcinoma of thyroid, pancreatitis. So some of the things you have to look at before you start these molecules. Is that all? No. Remember statins. So Caramello, bottom line is statin. Remember that for CV risk reduction, patients with CKD, diabetes, many of them, even if the lipid profile is normal, use add statin for CV risk reduction. So it's important to use the risk formulas if you can. They are all available online on Medcal. And then think target 70, even less than 55 LDL in high risk patients. So it's important. Don't forget the statin. What about aspirin? Aspirin is commonly put in all the prescriptions because patient seems a high risk, but not for primary prevention. So for this patient, if we start aspirin, it would be a primary prevention. So we wouldn't do that. We have to individualize, but secondary prevention for those people who have already had an event in the past, established ASCVD, prior MI, stable unstable angina, prior PCI or CABG, ischemic stroke or TIA, and symptomatic peripheral artery disease, definitely aspirin should be at the part of the prescription. So now how does the final prescription look like? Diet, lifestyle, smoking we've mentioned, you have to stop that. Then triple drug combination for blood pressure, metformin, DAPA, SEMA, and finerenone and rosuvastatin. Looks like a big prescription, but again, remember, starting molecules on time, you delay dialysis, you delay ICU admissions by 25 years. Is it not worth it? This is not what I say. This is the trial evidence from IMPA kidney trial. And in case nothing works, the patient is resistant to all your weight loss therapies, you definitely have bariatric surgery. But remember, the weight loss with the medications available now is equivalent to weight loss with bariatric surgery without the complications. So you have various types, sleeve gastrectomy, bypass you have, gastric banding you have, and a duodenal switch. They are also available. But again, if I were to be the patient, I would try out lifestyle first, that remains first and forever. Second, drug therapy, and this would be a last resort. So what would be the take home from my talk? Be aware of Caramello. It's not uncommon. It's not an unusual syndrome. We call it CKML now or CKLM, whatever name. Any patient walking into your clinic, I can say with conviction, 90% will have this syndrome. Only we have to look for it, check the weight, check the BMI, check the waist circumference, which we often don't do. Look at common investigations, which we are doing now. Thankfully, EGFR report is mentioned on the prescription. Please mention it. Patient can next day sue you. That doctor, you were supposed to look at this, you never did. And now I am in kidney failure. So make sure EGFR is on the prescription, albumin is on the prescription, and you look at the liver as well and the cardiac elements as well. So that's very, very important. Now, who should do it? Should the nephrologist do it or a cardiologist should do it? Who should be the key players in Caramello? The people sitting here, all of us sitting here, be it a primary care physician, a student, a gynecologist, endocrinologist, everybody, because these are the patients whom we see daily. The Caramello should be primary care driven because early integrated risk control prevents multi-organ failure later. The future of Caramello is prevention, not procedures, not dialysis, not ICU catheterizations. The best Caramello care happens before the cardiologist, nephrologist, or endocrinologist is needed. And in fact, I would say The innumerable number of dialysis units in India and the cardiac ICUs are monuments to our failure to missed prevention. So thank you for a very patient hearing.